This is an ultrasound study of the right kidney, in which you are seeing that this is the lower pole and this is the calculus. This is the proximal ureter that is dilated up to 13.6 millimeters, and I can trace this ureter up to its most distal end. Let's see. Okay. Now this is the length of the proximal ureter that is traceable, and up to the approximately, that I will let you know in just a minute. When I trace it upwards, you will see that it enters the kidney. Over here. So this is the proximal ureter arising from the, and then this is the calculus at the lower pole of the right kidney, and the proximal ureter is then traceable up to its most distal end here. This is the proximal region, and now I am moving the probe downwards up to the pelvic region almost. I am, and can still follow it, and from here onwards it's not traceable. So the total traceable dilated length of the proximal ureter is this is the proximal ureter, this is the distal ureter. So 11.4 centimeters or 11.5 centimeters of the distal ureter is traceable, that is dilated up to approximately 12 millimeters. There is no calculus seen within the ureter, dilated ureter, right ureter, and there is no focal lesion as well, no stricture as well. Up to its traceable then. So this is the total traceable length of the ureter. This is the proximal end, and this is the distal. This is the distal end, and this is up to which level I can trace it for you. Now there is something wrong with the kidney as well. Here you see the kidney shows multiple calcified areas giving posterior shadow, as for example, one is at the lower pole, this is the mid region, this is also at the mid region. Now the parenchymal thickness, if we consider the parenchymal thickness, so it is almost gone at the upper level. As you can see, this is the hydronephrosis the dilation of the calyces. This is a dipping sign, and only what can be made out is 7.3 millimeters of the parenchyma with muffled corticomedullary differentiation is seen at the upper pole. Now at the mid region, this is not a dilated callus, this is a rather prominent pyramid. This is the cortex. Now the cortex thickness is 4.1 and the parenchymal thickness is approximately 15 millimeters. So at the anterior mid region, the parenchymal thickness is preserved as well as the corticomedullary differentiation is also preserved. Now if we come towards the lower pole, this is the 12.5 millimeters, so reasonably fine, acceptable thickness of the parenchyma, normal echogenicity. What's interesting is that it gives you an appearance of medullary calcinosis. I am saying it gives you it is not medullary calcinosis, but it gives you the appearance of a medullary calcinosis when I will show you this in this fashion. If I scan it in this way, it appears as if we are seeing medullary calcification, calcinosis. However, what has happened is that all the calculi are stuck with the medullary region, and there is dilation of the proximal ureter as well. So there are multiple calculi seen. Calculi are at all regions, pushed towards the medulla, and then when you trace it, I am scanning with patient in left lateral decubitus posture at the lumbar region, and there is a scar over here. Patient has been operated before for renal calculus quite a few years back, and what I see at the region of the scar at the right lumbar region is a pocket of fluid collection in the subcutaneous tissue, right from the skin extending downwards up to the lower pole of the right kidney and iliopsoas muscle as well. Now if you see that this is the iliopsoas muscle, this is the pocket of abscess, mixed echo pattern, and it extends up to the subcutaneous tissue below the skin at the region, at the right lumbar region, just below the skin, and there are tiny calcifications also seen in it. So this is the extent of the abscess. Let's see how much its volume is. This is the longitudinal section. It measures 7.8 centimeters, 7.0 centimeters, and 4.9 or 5 centimeters, with an approximate volume of 144 milliliters. But when surgical intervention is going to be performed, it will be more than, it will be between 150 to 200 mLs. So this is an abscess which is just below the skin, This is also a pocket of abscess. You can see posterior wall acoustic enhancement a little bit. There, this is this, but in this here, the muscle is intervening. That's the reason you are not seeing the the posterior wall acoustic enhancement. I'm sorry, I did not include this portion. This should be included. This is part of it. This is part of the abscess in length, 11.8, and if I measure it like this, 6.2, and now the volume is 280 cc. So I will take it as this measurement being the correct one. So this is an abscess, pocket of an abscess. Now you see it's below, it's just below the skin at the right lumbar region, and it's only It's only 11 millimeter deep to the skin at the right lumbar region. 11 millimeter in length. So this is a abscess, perinephric abscess, as you can see. Now I'm going to show you, this is the kidney. This is the kidney, upper pole, lower pole, calcifications within the kidney that we saw initially, and there is a breach in the capsule, and from there you see a pocket of an abscess extending inferiormedially, just below the skin in the region of the in the right lumbar region. So this is a, now let's study the abscess only. If we study the abscess only, the abscess pocket contains thick incomplete septa, and look at the degree of mixed echo pattern, debris or different strength internal echoes. Now there are tiny calcifications also seen. These are tiny internal calcifications. This is a thick incomplete septa. This is a thin incomplete septa. So this is the abscess in longitudinal section. See, it's only 10 millimeters deep to the skin, and this is the pocket of abscess with mixed echo internal pattern and with internal calcifications as well. Now it can be a perinephric abscess with extension into the subcutaneous tissue, because the kidney is just you see the anterior wall of the left kidney. Now this is the kidney, and it is so close adjacent to the lower pole of the right kidney. It's difficult to make up, and perinephric fat is also not seen in this region. So maybe it's an extension from the infected material of the from the dilated calyces that has led to this abscess formation extending up to the subcutaneous tissue, expanding and extending into the subcutaneous tissue in a patient that already has almost kidney which has multiple calculi within it, as this is, you see that this is the proximal ureter, which is dilated. These are all calculi, and from this position, however, the lower pole appears to be clear of any abscess, whereas the area of the abscess is little lateral and in the subcutaneous tissue, with the iliopsoas muscle coursing posterior to it. So this is most probably a cold abscess. This is the iliopsoas. This is the source muscle of the right side. This is an abscess pocket and extending into the subcutaneous tissue, only 19 or 18 millimeters deep from the skin at this region. With internal calcifications. So this is the case of today. Thank you.